So this is first in-person education in over 2 years. So thank all of you that have come tonight, and thank everyone who is here on Zoom. And I want to introduce Charles Huckabee, who was gracious enough to tell us that he would provide this education for you. And he is actually a doctor of pharmacy from the University of Washington. He actually consults for 22 long-term care facilities, and he is certified in geriatric pharmacy. So he is perfect for us. He began his career in operations leadership for a long-term startup pharmacy, which I thought was interesting. Even more interesting, he's a pharmacist with 3 black belts in Taekwondo, and he brings the same level of focus and expertise to keeping long-term care residents safe and free from unnecessary medications. He thrives on the challenge of overseeing drug therapy and enjoys working with physicians to maximize effectiveness of medication. He's a part-time actor, which I'd love to hear more about. And his favorite movie is Star Wars, which explains his dog named Princess Leia.
Right.
So welcome, Charles, and thank you for being here.
No problem. Yes, I am a geriatric certified pharmacist. Graduated from the University of Washington in 2010. I'm just getting older and older. So as you get older, you see all the different alphabet letters at the end of your name because you just get bored, take a class and get educated. But anyway, so when I was in pharmacy school, we touched on dementia, and it was kind of a odd moment for me. I mean, I thought there was going to just be some amazing treatments and all this, we had just covered disease states where there had multiple different ways of treating it, and it was kind of a positive outlook. And then with dementia, it was 1 50-minute class, and then it was over, and it was kind of surprising to me. And so it's an interesting disease that I deal with all the time, being that I'm a geriatric certified pharmacist and working in long-term care. All of the people that I serve are usually 65 and older, and so with all disease states, as you get older, you'll see more and more, kind of add-ons, sadly. But so we can go to the next slide. Some of this is geared for med aides and nurses and whatnot. And actually, I prefer working with nurses over doctors. Doctors know everything, and that's that. And nurses are just cool. I couldn't do it without nurses, so they need to actually change that to I like working with nurses. But anyways, it's geared more toward medical personnel. However, I'll customize it a little bit. There'll be a video with Tifa Snow, which you all are aware of. She is awesome. But we will touch on some of the medications that they use for dementia. Sadly, there's not that many. It's more about the other medications that they're taking, because people with dementia, they can be totally healthy, and so, or they just have other issues going on that, that are being treated with medication. They have that dialed in. And so that said, every medication usually has a little bit of a side effect. So we have to make sure that those aren't going to worsen a person with dementia. So we'll cover that. We'll go over, let's see, non-drug interventions. That is a really big thing for me. Whenever I go to a facility and I see these antipsychotics or psychotropics on board for people, I really try to get them to focus on non-drug interventions. Now, certain states have different laws. Like in Oregon, you have to have resident-specific non-drug interventions. Washington, that's not necessarily the case, but I don't differentiate between skilled, assisted, Oregon or Washington. I treat everybody the same, and because I've noticed that in the skilled level, you'll see people with they have a high acuity. They'll say, well, in the assisted living, I'll see the same acuity level. And so why should one have different laws and the other one not? And so I treat everybody the same with non-drug interventions and requiring it for facilities to do, because it's easy to just throw a pill at somebody and say, hey, calm them down, but that's just not appropriate. I don't want my mom or dad, or I really don't want me to be treated that way when I get older. And so that's kind of my job, it's half pharmacist, medical personnel, and half kind of cop, I guess you could say. So then that goes with the non-drug interventions, kind of slides into the antipsychotic use, which that is commonly used. It's not FDA approved for it, but yet providers, they tend to write for it. And so it's my job to make sure that we keep those in safe levels. And then, preventing dementia, we'll touch on that a little bit. And so we can go to the next slide. Oops, a daisy. So when all disease states are going to have a hypothesis. One of them is the cholinergic hypothesis, that a person they lose this neurotransmitter, and loss of that causes them to have dementia. And so you'll see these medications like Namenda and or cholinesterase inhibitors, which is like Aricept. They'll try and basically reverse that. They'll keep those transmitters kind of level high, and you'll notice that it has an effect, but it really doesn't have a long effect, sadly, with the medications. But that's the hypothesis. Acetylcholine depletion, boom, and then you get meds that come out of that hypothesis. And you'll see that with other disease states, that they'll just have, this is what we think is going on, so we're going to make meds to make that work. Like with depression, they think serotonin, and so they'll make these serotonin reuptake inhibitors just to kind of work on it. And it seems to work for the most part, but I'm not sure exactly how they developed that kind of thought process, but that doesn't really matter. Okay, so let's go to the next one. Okay, so if you look here, I mean, it's pretty straightforward. I mean, normal aging, everybody, as you get older, you're going to have cognitive decline. For example, today I got out of the shower and I forgot to rinse the shampoo out of my hair. So that was nice. A towel on the hair. It's interesting. So I totally forgot about it. And so, you know, as you get older, you know, you have these reserves. And like when you're younger, I felt like I could break my ankle and just rub my ankle, and then the broke ankle would be fine. But now I'll be sitting down watching TV and, you know, stand up and, you know, hurt a hip or whatever, which, by the way, karate is awesome. But how you knew I was going to be a geriatric pharmacist is I have a fake hip. So I'm trying to get real close to my patients and their feeling and stuff. But anyway, so if you look here, I mean, it's like a lot of things. As you age, things decline. Now there is a normal aging, but then there's obviously going to be a different type of aging that is not that's not normal. And so the MCI is mild cognitive impairment. That is where you basically you don't have dementia, but there's a chance that you will progress to it. But your memory, your memory is just affected a little bit more. It's just, they're just the different stages. And so if once you get to dementia, you'll see, and you all are probably have a loved one that you're dealing with dementia and whatnot, you'll start to see different changes in behaviors, the exit seeking and the sundowning and all that. And so that's usually when you're in the dementia part. And a lot of it, there's really no test per se to test if you have dementia. It's kind of usually a family member is noticing something, different with their parent or whatever. And it's just kind of a whole bunch of things together that they come together and decide, if this person has it or whatnot. So go to the next, please. Okay, so these are our numbers of Alzheimer's disease. So there's 35 million people diagnosed with dementia globally, and in the US, it's 5.3 million. Obviously, as I was saying, it increases with age. And then, a lot of the disease states, you'll see different groups of people affected more, like, for example, African Americans with hypertension are really challenging to get their blood pressure down. And, and with here, it's African American and Hispanic tend to have it more. It's, we don't really know why, but you'll just see that with different disease states, the different races will have different types of numbers. And so if you look at there, of course, with everything, 5.3 million, then they have to guesstimate on how, years out, how many people will have approximate Alzheimer's disease. And by 2025, which we're getting pretty darn close, we're looking at about 7 million. And then 2050, it should triple by 5.1 million, which I think a lot of that is, like you'll see, like the baby boomer generation, that is really starting to enter the facilities. And there's just by the name of a baby boomer, well, there's a lot of baby boomers. And so you'll start to see these numbers kind of increase more than you would be, with another group of people. All right. Okay, and again, going with age, but if you look like at 90 years old, if you reach 90, which our neighbor Joe, I believe, he's 93, he has a rock star. So let's go 65. So it's actually around, I want to say, a little between 2 and 4%, but let's just stick with this graph for, to be official. So at 65, 2% of people will have Alzheimer's, and then you just see it dramatically increase. So it's actually, once you're 90 and above, you'll see about 50% of that population with dementia. And then, of course, with dementia, that's just kind of like an umbrella term. There is different things, different groups underneath that. So there is Lewy body dementia, vascular dementia. So Lewy body dementia, you'll see people that have Parkinson's. I was just hearing about somebody who had a loved one with Lewy body dementia. Vascular dementia, someone has a stroke and you end up having cognitive effects. And then, of course, there's Alzheimer's. And so if you look at the three, that basically takes up a big piece of pie of all of that dementia that you always hear about. It's just kind of an easier way to say dementia than, each individual thing, but that's the three main ones. Now, this lady is way cooler, way funner than I am, and these are nice little early warning signs that I think people should see, because you never know when your loved one, they might be acting weird, and you're like, what is going on? And so, because there's a big difference between being tired and going down that road of dementia. And so my brother, he's always trying to diagnose my mom, she's got dementia. And I'm like, no, she's tired. It's a normal process, and so it's important to kind of differentiate between what is normal aging and then what's dementia. And she breaks it down very good. So, yeah.
Here are your early warning signs. And I'm not going to spend a lot of energy or time on these, but I want to just give you a hint. If I am really, really good at telling you, do you remember that one time when you were a little boy and I'm telling you these old stories over and over and over, and yet when you try to get me to hold on to new information, I can't do it, be nervous. Because I should not have more trouble hanging on to important new information than I can access that old stuff. And when you start seeing it pretty regularly, a pattern of it, not just once or twice, but a pattern. Okay. You also want to look for having difficulty doing difficult but familiar things, like paying the taxes rather than putting them in a drawer somewhere. Seeking out a financial advisor and then telling him to do stuff that I would never have told him to do, and then claiming I didn't tell him to do that. Taking money and moving it around, and it's like, what are you doing? Well, I needed to move it around. Trusting people, not kind of people I'd ever trust. Sending money to a post office box in Oklahoma, if it's not my habit. Taking all my money out of the bank and keeping it at the house. Inviting people into the house that I don't know to come and fix something. Okay. We also want to look at problems not just with memory, because that's not what it's all about. We also want to look at problems where I can't think of the thing that you say, one after the other in a row, and there's a dot at the end. Not a sentence, huh? Words. Yes, words. What'd you think I meant? You get such an attitude. Now, this woman gave me the answer. Why am I being ugly to her? Because I felt stupid. Because I should have known what it was, and I didn't like not coming up with it. Let me give you another example. Not everybody gets angry. Let me show you another example of this same kind of thing, though. It's the one after the other, and you put them in a thing, and there's a dot at the end. Word. Oh, my God. Why couldn't I think of that? No, it's not okay. It is not. Now, I wasn't mad before, but now I'm going to get mad. Why? Because she told me it was okay that I was stupid. Oh. Is that what you meant to do?
No way.
Well, that's what you did.
I'm sorry.
Well, you are sorry. This whole situation is sorry.
I'm just a damn fool.
Well, you are.
Yes.
You're going to go straight to hell, too. That'll be okay. Now, this is where it feels like, and I'm going to be honest with you, sometimes as a care partner, it feels like no matter what you do, you're not right. It's because this disease makes it so hard for me, because I think I should know something. When I don't know something and you give it to me like that, it proves to me I don't know something that I know I should. I have a PhD, my God, I should be able to think of the thing that it's called. Now, if this just happens when you're exhausted, when you haven't had any sleep, when you're really, really worried, and it only happens every now and then, see, this is the tricky part, because everyone in this room is going to say, well, I've had problems finding words. Yeah, I don't think that's it. I mean, everybody's scared of dementia, by the way. They did this study with older adults, and it used to be, what are the thing you're most scared of? Guess what it used to be? Cancer. Guess what it is now? Dementia. Yeah, people are much more scared about this thing than they ever have been before, because the numbers are going up and people realize how scary this is. So what happens is we start seeing some changes in us. We're trying to discount it. So one of the most common things, somebody says something like, I'm a little concerned. I can't seem to find the things that I want to say sometimes. You know, the things that you want to say to people. Now notice how I used vague terms to describe the thing. You know, the fattles that go one after the other, the fattles. The fattles. Fattles. Do you speak English?
No.
Well, shit. Now, these are all kinds of behaviors that just sort of, as you're seeing them, you're thinking, God, what's going on here? And yet on other times, I'm perfectly fine. I could come up with words that aren't real words. It's called word salad. On the other hand, I might just speak vaguely. On the other hand, I might quit talking. It's real easy for us to sort of think, well, you know, all people do that. Not to this, and you want to think of me. Who am I? What have I done? And if it's not consistent with me, you don't lose your speaking skills with normal aging. You are a little bit more of who you've been, but it doesn't change dramatically. Your verbal linguistics stay the same. You're a little slower, but it's still the same. You have the same vocabulary. You actually have more vocabulary than you've ever had before. But it takes you longer to go find the words. So if people rush you, you will still hear anybody normal aging. Could you slow down just a minute? I'm going to tell you. That's normal between generations. It's also very normal for husband and wives to get on each other about this. Because I'll start, you know, I was going to tell you that so-and-so came by yesterday. Yes, and he stopped and he said he was going to fix it. Can I tell the story or are you going to tell it? This is where sometimes you got to sort of sort out what's normal interactive behavior between people and what feels different. But after you've been around it for a while, you'll start to pick up on it if you're listening and paying attention. Another one is getting confused about place or time. So this is that getting lost driving business. This is getting on the interstate and getting turned around and not being able to think of which exit I'm looking for. It can also be getting lost in my life for a moment. So in a moment, I'm looking for the house I grew up in, not the current house. And so now I get to a place and it's like, God, how did I get here? Because I don't remember the process, because I can't hold on to new stuff. And all of a sudden, I don't know why I got here. How did I get here? Somebody brought me here and left me here, and I'm here all alone. Oh my God, who is this? And I might look at somebody I've known very closely for years. And in that moment, who are you? Who are you, by the way? And you're my wife. You're my husband. Because in that moment, I'm thinking I'm 22 in that moment, and I am looking for the person in the wedding picture. And so what happens is I look at you and you scare me, because it's like, oh my God, what are you doing in my house? Who are you? Especially at night. And my daughter is there, and it's like, who are you? What are you doing here? Mom, you know who I am. No, I don't either. Who are you? I'm your daughter. Bullshit. I don't have a little girl. I have a little girl, but not anything as old as you. And you focus in on my distress, but what you're not realizing is how scary this is for me. I mean, this actually becomes really scary, because in that moment, I'm lost. And so when my grandfather would say, where's Grandma? He in that moment truly believed he was in a place in his time in life that it would make sense that she was there. And when my mom would say, well, Grandpa, of course she's dead. Oh my God. he would grieve again the loss, and yet he couldn't hold on to that loss. So that's not the right answer. That's called reality orientation. We don't do that anymore. That's an old thing. We gave that up. It's not good for people. Worsening judgment. These are things that people are making bad choices. Problem-solving issues. These are people who you can go all the way. Now, this is why I don't think it's a good, oh, I hear you. So this is what I think we ought to do. Oh, okay. So why are you taking my car keys? We talked about this. Well, I never agreed to that. You did too. I did not. The combination of the memory problems and the reasoning skill problems will wear you out if you actually think it's going to stick. Because you get frustrated because you said, we talked about this already. You remember the talk. I don't. You've got to give up the idea that I hold on to things all the time because I can't. And so when I say, well, this is the first I've heard of it, your gut reaction, your automatic response to that, it is not the first time we've talked about this. You got to quit, stop, back up. Now, I actually want you to practice that. That is an important skill. I want you to stop. I want you to breathe in, purse your lips, and blow out. Now, this time I want you to focus on belly breathing, okay? In other words, abdominal breathing. We're going to get to this and tell you how important this is, okay? Ready? Breathe in through your nose. Blow out. One more time. Breathe in. Blow it out. Now, the reason I just had you do that, that's a new skill for you. It's called breathing. Most of you think you know how to do this, but when you're a caregiver, here's what starts to happen. You start to get stressed in caregiving, and before you know it, before very long, you are actually not breathing out. You are sucking air in, and you are holding on to it, and you're only using the top third of your lungs because you've got issues. There are issues. Every time I go over here, there are issues, and I don't have time. When am I going to have time to do anything for me? I am stressed out. Let me tell you something. I can't put, and what you don't realize is you're not breathing. You're sucking air in, but you never let it go. And letting it go is an incredibly important skill, both in how you deal with things, but also in just simple breathing. So they did a study. They did a study of people who are caring for people who have dementia. And they looked at them, and they compared them to people who were not caring for people who had dementia. And guess what they found out? These people, oh, that's a signal. It means we've almost been about 45 minutes already. Okay? Let me check in. Have you learned anything yet about dementia that you didn't know? Some of you, yes, some of you not. How about some new skills? Well, you're learning one right now, and are you having some fun? Okay, well, good. Okay, well, then we're coming along. We'll see what we can do with the rest of this period of time. All right, so they did this study, and what they did is they compared people with dementia who were caregiving for people with dementia and people who were not. And what they found is people who were caregiving for people with dementia had cortisol levels, negative stress hormone, that's 50% higher than the normal person. Now, cortisol is a negative stress hormone. It's not good to have in your system for long periods of time. It's really a good thing to have if you're being chased by a tiger and you want to get away from them really quickly. But if you're not doing that, you don't really want to have high cortisol levels, because high cortisol level increases fat distribution in your organs and around your middle. It makes it very difficult for you to see the big picture. It actually causes your vision to go like this. It keeps your brain from working really well in decision-making tasks. You cannot make good decisions when your cortisol level, because it's a panic. It's sort of got to make you got to do something. You got to move. You're not able to see the big picture and sort of make good decisions and choices based on information out there, because you can't handle all that. It also raises your blood pressure, your heart rate, and your blood sugar. Therefore, people who are caregiving for people with dementia are more at risk for developing dementia themselves. Oh yeah, that's not good. We don't need more people with dementia. There's plenty. So here's what we want to do. They did a study and they said, okay, well, you guys are super stressed. Guess what caregivers said? Oh, good, something else I'm not doing right. Great. Well, what am I supposed to do about that? I don't have time to get done what I need to do. How am I supposed to deal with stress in addition to that? And so they said, okay, well, we need to make this simple. Let's have them breathe. So they actually did. They had them stop 5 times a day and take 3 deep cleansing breaths. And they actually gave them a kitchen timer to put on their belt. Because guess what happens to caregivers if you don't give them a timer to remember to take care of themselves? They won't. You people don't take care of yourselves. You say, oh yeah, I'll get to that sometime. But you don't. So 5 times a day they would stop and they would do those 3 deep cleansing breaths. And after 6 months, they remeasured their cortisol level. It was back to normal levels. What does that mean about you as a caregiver? You are carrying an incredible burden around and you don't even realize you're not even breathing well. You are going into situations, and I'll tell you how you walk in the house for the person. Hey, Dad, how are we doing today? You gonna be ready to take a shower? Okay, let's not fight, Daddy. You're filthy. This is gonna go real well, I can tell you, just don't go there. But this is where, but notice what I wasn't doing. I'm not breathing. And unfortunately, guess who picks up his cues from me? Daddy. And so now Daddy's getting more and more tense and more upset. What is it you want to do? And before you know it, you two are going at it again without even realizing how you got there. Okay? We've got to change our behavior so their behavior will change. But it's only going to happen if we're the ones who change first. We've got to be willing to make that shift. So breathing regularly, really, really important. So when you can think of nothing else to do, step back. You're not wanting to take a shower, I hear you. It's a much safer response. It's a response, not a reaction. You're actually thinking about what you're going to do. You're taking that moment to get yourself together before you try to help somebody else. You know what they say about that oxygen mask? Well, it's the same thing when it's caregiving. You've got to move out of caregiving to care partnering. So it means you have to think. Okay? Now, we can go over the rest of these, but I don't want to spend a whole lot of time. I do want to point out a couple of other things here, though. The loss of initiation. That's probably one of the ones that gets missed the most. Loss of initiation, it means I'm not doing things like I used to. I will talk about it, but I don't do it. So let's say I used to be very active in my faith community. I used to run a group of adults, and we do study. And now I've said, well, you know, I'm not going to do that anymore. That I have given them a lot of time of my life, and I let somebody else step forward. Let somebody else do this kind of thing. I'm just not going to do it. Or I'm not going to go to church this Sunday, or I'm not going to go to temple this Sunday. I'll do it another time. I'll do it another time. I'm going to clean that up. I'm going to clean that all up. I'm going to get in that room and get it all dealt with. And not a thing gets done. It could be depression, but it might not be depression. It might be the first signs of dementia. Because one of the things that their brain can't do is figure out how to go from a thought to actually doing it. And so they get stuck. And so you get home and it's like, Mom, you didn't even eat the sandwich I left you. Well, I just wasn't hungry. It wasn't about being hungry. It's about not being able to get started, not being able to figure it out, not being able to know what to do first, what to do next, to sequence through it. This is where you go in and you see the bedroom, you're like, what have you done? Well, I was going to put it all away. It's all out. I know, I was.
Okay.
All right, so as you can see, she didn't give any like markers that I say, hey, you have dementia. She's saying these are the signs that you will observe this dementia. And this is just a pretty much kind of an overview of what she's saying as far as this, you know, you have the suspected dysfunction going on, of cognitive dysfunction going on. And then you're going to branch out into the different categories there. But again, this is just a way of saying exactly kind of what she already said, that, you know, you just know there's something different about that person. That, you know, it's not that they're exhausted, there's just something else going on. And so it's not as simple as we would expect trying to, you know, get to diagnosing them, but we eventually get there. Unfortunately for me, it's a little out of my specialty, the transition to the memory care world, because where I'm at, I see them if they're in the memory care units and the locked units and they have advanced dementia and whatnot. And so it's interesting to see her talk about the different things that you guys in the community are seeing with your loved ones, prior. So yeah, go to the next. Okay, so again, this is just overviewing some of the things that they'll do. There's a mini mental score that we'll do. There's a different test that they'll have a person try, like one's drawing a clock and different things to see how your memory is. There are a few little lab screen, but for the most part, it's just the process of elimination. And so, yeah. And again, with the physical examination, a lot of the people with dementia, they're healthy, and so it's just their brain has let them down, unfortunately, and but they're super strong, they're super healthy or whatever. It goes back to the story I was telling about a resident who, this guy he used to be a college football player, and he would physically get aggressive toward the med aid staff. And so, this guy had a lot of strength, but, we're going to later on cover up what they ended up doing to make it where he never was, never had any physical aggression after these non-drug interventions took place. But again, you can be totally healthy and still have dementia. And again, that's the clock drawing, all that stuff. We can skip ahead. Now we get to where my world is, which is drugs. And so there is a lot of drugs that affect people with dementia more than a person that doesn't have dementia. And so that's actually where my role is I go in and I look at medications that are used for blood pressure and all kinds of different meds, and look at their properties and see if those are appropriate for a person with dementia. Benzodiazepines, that's what they like the Xanaxes of the world and Ativan. They'll give that prior to showers. How she was using the example of approaching her father for showers. Well, that is a real issue with some people where it's like you just cannot get them to shower, and so you have to come up with different ways of getting them to do it. And unfortunately, the Xanaxes of the world, those are thrown in there to help relax this person and get them to get their shower, because or else they just won't get cleaned. Then of course, pain. So a lot of time with your behaviors, I hear the word behaviors all the time, behaviors. Well, that's just like a broad term for that person trying to communicate. So the person could be in pain. Of the people that the 5% that have Alzheimer's at age whatever it was, 65, 50% of those are people that have behaviors is due to pain. Well, when you lose the ability to communicate, like she was saying, how the early stages of them not being able to fully form a sentence and whatnot. Well, when you lose the ability to communicate, it comes out as these behaviors. And so whenever I have a facility contact me and they say, hey, Mr. Johnson is, swearing and yelling and doing all this crazy stuff, the first thing I ask, do they have a urinary tract infection? Are they in pain? And so a lot of the behaviors that you see are, it's not that person is a jerk, it's just they have something going on that they don't know how to communicate with. And so you'll see analgesics come into play, which, so, and again, a lot of the people in my world, they have osteoarthritis, they have all kinds of pain going on. And so it's funny, they did a study where they were showing people with dementia, suddenly they had no pain. So they didn't need any pain meds. Well, that doesn't happen compared to people of their same age. Well, that doesn't happen. It's just the people that were able to communicate were saying, hey, I had a knee replacement or a hip replacement, I hurt, and the person that had dementia, they weren't able to communicate. And so there was a very under treating of pain in that population. And then there's anticholinergics, which is, that's a property of a drug that I focus on the most with all drugs for geriatrics, which is Benadryl is basically the poster child of anticholinergic effect. It's not recommended in geriatrics, so 65 and older. It's part of the Beers criteria, they call it, which is medications that are inappropriate for geriatrics. And so Benadryl is, it has its purposes, for allergic reactions and stuff like that. And people use it for insomnia, but I try to, I don't like it to be on longer than a week because of that property. And it has cardiovascular effects, so it can, mess with the person's heart. And as you get older, a lot of times you have some heart problems and whatnot. And so that's a property that is a swear word in the pharmacy world, I'd have to say, is anticholinergic. And next one. Yeah, well, we could keep on going. So Benadryl, Dramamine, I don't really see too often. And then, of course, you know how she had mentioned, is this the person with dementia or depression? Well, a lot of times they come hand in hand. And so you'll see medications added for depression with people that have dementia. And one of them is a class of medication they call the tricyclic antidepressants. Don't worry about it. Amitriptyline, that has that anticholinergic property. And so these are things that I look for to remove in that population because it just worsens their cognitive, it just makes them just a lot of the medications. Actually, the best way to put it is there's a medication, Aricept, that we'll be getting to. It's a acetylcholine inhibitor. Well, anticholinergic, if you take an anticholinergic, so you're trying to increase the enzyme, right? You're trying to increase choline, but if you take one of these like amitriptyline or Benadryl, now you're decreasing it. And so you're kind of fighting medications to treat dementia, but I'm going to walk away from this because I could not next, what's left is for me to start talking about pharmacist stuff and you guys will just be like, okay, move on. So we'll just go on to this. Okay, so you'll also see in, actually just in geriatrics in general, delirium. So if some of the people will get like a urinary tract infection and all of a sudden they just start acting crazy. And you're like, what is going on? Like, why is this person just freaking out? Well, delirium, that's a real thing. And unfortunately, delirium will land people in the hospital and then they'll transition into like a skilled or assisted living. And what they do to treat delirium is they throw these antipsychotics on board. Well, those have anticholinergic properties on top of all kinds of nasty things. And so delirium is a real thing that you'll see in just the geriatric population in general. But again, if you're dealing with someone with dementia that can't communicate and they're, you're just seeing odd behaviors, that's definitely one of them. And so medications can also worsen that as well. And so that's kind of where my world is. And then next. So of course, with all things, you want to reduce the cognitive symptoms, the behavior symptoms, of course, ultimately slow the disease progression. And then for people that maybe have mild cognitive impairment, again, with that, it's not quite dementia, but we've seen that if you have mild cognitive impairment, you do tend to have a higher chance of it transitioning to dementia. And so there's certain medications with that anticholinergic property that we want to slow taking that because there's a theory that taking medication with that property can lead to dementia possibly. So, and then with each disease state, there's always, hypertension. You have hypertension 1, hypertension 2. Well, it's the same thing with Alzheimer's disease. There is mild, moderate, and severe. And based on those categories, different medications will be prescribed. And so, yeah. Again, that goes back to that hypothesis of as we see less production of acetylcholine. And so then a lot of the medications like the Aricept is a acetylcholine inhibitor. So yeah, right there, Aricept. And these, again, it's kind of sad to only just see this. This is it. You have your acetylcholinesterase inhibitors and then Namenda. And I'm going to skip past the studies that I have, but basically they're only effective for about 6 months. So when you take them, you'll see stopping. The progression will slow, but really ultimately it's only 6 months or so that they're effective. However, it's easier said than done to remove that medication from people. And so for the most part, they stay on board the entire time. I mean, I'll have people on hospice where I'm like, okay, maybe we should consider getting rid of them. And there's going to be a family member that's like, nope, that ain't happening. And with me, I do send, letters to the doctors and whatnot, but I go to the facility first because there's always a family member that is, not always, but there's a chance of a family member that's handling their medication, and I never want to bypass them because I actually had a daughter call me once. The doctor agreed with my treatment, and some lady called me and she was so mad, like, how dare you, I'm doing all this stuff, and he reacted like that. And so yeah, I'm not sure where I got to this part of the conversation, but yeah, anyway, so we can move to the next one.
I have a question
Yes,
on that last slide.
sure.
If you have a patient that's taking those drugs,
Mhm.
and it's been past 6 months,
Mhm.
say it's a year, 18 months.
Yep.
And the doctor, the neurologist is saying, stay on the meds.
Sure.
What
I don't have a
choice
problem.
do you have, and would it hurt to phase out of them to see if any changes happen?
I wouldn't be expecting a change to happen from phasing out of it. In fact, there's a little bit of information that came out that have found that people that are on those, even though it's not slowing the disease, they have less behavioral problems. Whereas when I was in pharmacy school, they're like, do not add that for behavioral problems. And so, once I heard that, I'm like, yeah, okay, fine. I mean, I guess I'll keep them on board. I rarely ask to get those removed because you're not going to see improvement in anything. And, a lot of people, they base it on hospice. They'll be like, oh, well, they stopped all their medications and they rebounded. And I always scratch my head, like, how is that possible? Well, you don't, just because you're on hospice doesn't mean you're dying, actually. It just means you're failing to thrive. And so, it wasn't actually that they just improved, they just were suddenly, they weren't failing to thrive. And so that I wouldn't think that removing it would be negative per se, but you won't see an improvement if that's what you're curious about. I mean,
Well, the person I'm thinking of would like to decrease the number of
gotcha.
drugs that he takes.
Oh, gotcha. Well, I would see that it's a tough question because for me, I'd have to see their medication list because that there's a lot of other medications that should be removed before that, I guess. It's not a wrong answer to get rid of it when you hear 6 months it's only effective. But again, when you're looking at your mom or your dad and someone wants to take that medication away that is supposed to help with dementia, I mean, I'd probably want to throw down personally, but you ain't taking that away. So
Would you
I can
have
see.
time to review the medication list?
Sure, yeah, it's easy. Yeah, no problem.
After.
Okay.
Thank you.
Oh, hey, no problem. And with these, the biggest thing is GI side effects. And so I'll have a doctor take Aricept and prescribe it for at bedtime. So then, they'll sleep through with the GI side effects. But for the most part, they're pretty well tolerated, and there's not very many drug interactions with them. So that's makes my life easier. Okay. And again, we're just going to skip past these medications because it's a little, yeah, right. No, there was studies, double-blind, random controlled studies. Okay,
Charles, can I?
Go for it.
Can you speak to the use of Aricept and Namenda together?
Yes. Okay. So there's different stages of dementia. There's mild, moderate, and so usually Aricept is the first medication that they'll put on board, and they usually put about 5 milligrams, which is actually therapeutic at that dose. So I would recommend starting there for, it's tough to say how long you would want to start at that. In theory, it's actually only 30 days that you would stay at that 5 milligram and then you jump up. But at least with Aricept, right off the bat, it's therapeutic. Whereas Namenda, you have to do this taper. It's like 5 milligrams for, in the morning, and then 5 milligrams at night a week later, and there's this slow taper up. And once you get to 10 milligrams twice a day of Namenda, then you're therapeutic. Starting to see doctors prescribe at 5 milligrams twice a day with that, which is interesting to me. But you usually start with one, and then once you advance, then you throw on the other one. And so I don't ever see Aricept and Namenda given right away, like at the first, thing. It's usually just a stepped up approach, but it's very common for them to be together. And once I see that they're together, I know that they're in that moderate range versus mild would be more of an Aricept just by itself. Does that answer it?
Yep.
Wait. Let's see, we can move on from that. We're all kind of saying the same thing over and over and over again, but this is where I live, which is the non-pharmacological treatment. I'm like a weird pharmacist. People think, oh, how many pills do you see you're a pharmacist? I have not counted a pill in about 7 years. And so I tend to go for the non-drug interventions. When I look at medications, I try to remove them, which I don't think people ever connect pharmacists. I think people connect pharmacists with being weird. Like It's a Wonderful Life. I mean, the old guy, he almost poisoned, a patient. And then I think Desperate Housewives, the guy was a serial killer. So that's the only thing that people think of a pharmacist. And so and dispensing meds. And so I try to get rid of these and have people focus on this non-pharmacological treatment, which it's amazing how much it works. I was mentioning a story earlier where there's this lady where she was like racist and she'd say racist things, that is, and just was very it was hard to review charts next to this lady. She was pretty mean. Well, one day I'm walking into the facility and I hear a seagull inside this facility, and I'm like what? Like, what's going on? Am I going crazy? And it just kept on going. Well, and she wasn't swearing or doing anything. Well, they found out that, and I had been preaching, hey, you need to find out what this person did. What did your mom like? What did your dad like during the, growing up and whatnot? Find out things that they liked. And she liked to sit by the ocean and hear seagulls. And they bought a robotic seagull and brought it in her room. And I never heard her swear or anything. And so until she passed away. And so that was pretty amazing for me to actually see it firsthand, because if you go into a memory care unit, it's pretty jarring to see someone with advanced dementia. And I could read it, write it, tell you all about it all day long, but until you actually experience it, it's initially it was kind of frightening. I mean, I had to review charts at the end of the table, and there was someone that was just repetitively going like, no, and yelling and slamming and hitting the table. And it was like, wow, until you see that, you really, it drilled into me the importance of finding these specific, resident-specific non-drug interventions. Not just blind, take them for a walk, give them a coffee, and I'll see that every now and then. They'll just do like a running order of the same thing. I'm like, so they all want coffee and they all want to go for a walk? I mean, I don't want to go for a walk and I don't like coffee. And so I make sure that they have things that are very specific to that person. Like one lady, she liked to watch this TV show at freaking 3 o'clock. She watched it all the time. I'll be darned, you take her and you put her there, she just calms down and she's happy, And Tipa Snow, she mentioned about not if a person with dementia is asking about something, to kind of like not lie to them in a sense. Well, I've seen this many times where there's this lady, her cat at 3 p.m., her cat needs to be taken inside the house. And every day she would come up, my cat needs to come in in the house, and the med aide, oh yeah, I brought the cat in, it's right in your bedroom. And then she just turned around and walk away. So I'm on the fence on whether that's a good or, I think she's kind of put it as a negative thing. But honestly, I mean, when I see someone that's confused or stressed, she was actually really stressed over this cat. And so just identifying and personalizing it, the treatment, it's amazing how much that will improve. And of course, there's certain times of the day that I'm just jumping ahead on the slides, so that doesn't matter. There's certain times of the day where suddenly you'll see behaviors occur, and they call it sundowning. And so just identifying these times when a person is having these behaviors, and then starting to personalize it and identify with that person, not just a blank, do my job and whatever. You'd be surprised how much a person improves. And so, of course, if you have dementia, it's usually a disease of geriatrics. And so you're going to see other disease states. You're going to see hypertension, cholesterol, high cholesterol, and they're all on that medication. And again, some of those medications, well, most medications have a side effect, but they're going to have more of a side effect with the person. If you are having a hard time with your cognitive, if you're having a cognitive deficit and now you're taking a medication that's making you lightheaded or messing with your blood sugar, it's going to affect you a lot more than it would a person that doesn't have that. I don't know if anybody here has diabetes, but if you've ever experienced low blood sugar, you feel weird, you feel like you're just about to get into a car accident, you slam on that brake, that feeling right there, that's your low blood sugar. Well, imagine someone that has a cognitive deficit with dementia, how that's going to affect them. It's going to be a lot more for them than it would be for us. And so it's important for my standpoint is to making sure that all those things like the blood sugar and hypertension is being treated appropriately. And how Tipa Snow is talking about the cortisol. Well, a lot of people, so prednisone is basically the tablet version of that. It's different strength, but cortisol is what we have our native steroid, I guess you would say. Well, she was saying blood sugar effects. Well, a lot of the people that with dementia, they have COPD and they'll be on prednisone and whatnot. And so again, medications that you this is actually overall what I would say the biggest thing is, look at the medications that your mom or your dad or whoever it is that has dementia has been on. And now that they have that diagnosis of dementia, you want to look at those medications as if, okay, now we're re-prescribing basically. We want to, don't stop taking them, but you want to go to your doctor and you want to reevaluate these medications because not all of them are going to be appropriate based on this new transitioning that the person has. And so you got to look at those medications in a different way, because as you age, there's your liver and kidney function change, and especially with dementia and whatnot, and you'll have some just heightened side effects, I guess. You'll be aware of them, and so you got to be careful. So with your medications, just make sure that you take that to a doctor. And I'm assuming the doctor that's diagnosed with dementia has already done that, but again, you'd be surprised. There's some adjustment and other meds that you can do that will help with your loved one with their dementia. Okay.
I have to go.
Are we at the end?
The rest were medication specific.
Oh, yeah, just keep on going. Yeah.
Okay.
So, there's some hypotheses on prevention. So there's anti-inflammatory drugs like NSAIDs, but even your cholesterol medications, they have an anti-inflammatory effect, and which is the statins. But for the most part, this is just kind of not really, there's not much evidence for its support, but still, at least you'll be aware that there are some possible things that can help prevent dementia, which is again the statins and anti-inflammatory. So something to think about. Why not? Oh, there's my dog. Look at that, Princess Leia. She's so cute. So that was actually a PetSmart commercial, but she didn't get it. How did that dog with an ear down and the ear up not get that? Anyway, so yeah. Any questions? I'll answer it. No problem. I'll try to at least.
So people that are here, just ask your questions. People who are, I don't know if they can hear me or not, but people on Zoom, if you'll put it in the chat, we'll see that it gets answered.
I was wondering if there's been any investigation into the disparity of the amount of people diagnosed in the United States with dementia, 5.5 million, as opposed to the world, 35 million, which is about 16, 17% in the United States, when we constitute about 3 to 3.5% of the world's population.
It's the level of reporting. So my topic that is dear to my heart is COPD. Well, the biggest thing with COPD was the reporting of it. There's just, so you'll have access to the medical world in the US, that'll be a better access to treatment versus another part of the globe. And so it's pretty much access to treatment to, go see a doctor to be diagnosed. And so that I would lean toward that being the biggest thing, where you see these big changes in percentages, where it's like, why is so much there? Like if you go in the US, like in the East, on the East Coast, there's really high antipsychotic use versus the West Coast. Does that mean they're more crazy over in the East Coast? No, it's just, there's just different. Yeah, okay, maybe I am a West Coast guy. Yeah, right. Okay, you got me. But it's just, it's access to medical, doctors and whatnot, that you'll see the percentage differences.
Well, the reason I asked too was, I've seen some talks about over medicating people, bringing on, symptoms, if you will, of dementia. And you talked about that and weaning people off some of the drugs.
Benadryl, I mean, that, not to be knocking on Benadryl, but that property right there, I mean, it can make a person just seem out of it, and a lot of these antipsychotics, there's a side effect that it sedates. Well, you'll see it where it'll just be as needed. I'll see it for a resident with dementia. Well, I know that doctor is using that as a chemical restraint. And so a lot of the medications, like I said, OTC, Benadryl, that would, if you take it, can make you feel woozy and make a person be like, hey, what's wrong with this person? I mean, if you see a person that's on an opioid, I mean, if they take too much of it, you're like, yeah, there's something weird with this guy. And so, yeah, so that I'd say from an at-home, OTC item, those are the ones that you want to look at, like the allergy medications kind of across the board would have that property that you want to be careful with. Don't take it. I mean, you can, it's just, people, they go crazy with stuff. So anyways, yes.
I was curious about the non-drug treatments,
Mhm.
like deciding, in discovering what someone's interested in and how important it is to them. Any suggestions on how to go about that?
Well, what I do, because I'm at the facility level, they don't know who this person is. I have them go and talk to their family members, go talk to them. And that's the biggest thing is just, family members are going to know it. I mean, unless you didn't know your mom or dad, which I mean, that's possible, but that's the biggest thing is identifying that. And I mean, yeah, that's all I got. That's my trick.
What about if they have a whole list?
Yeah, well, I mean, when I see the non-drug interventions, it's actually 3 that they have to try, and it's pretty simple. A lot of them is, like reassuring, the walk thing. I guess a lot of people like to walk, believe it or not. I guess us Americans are in better shape than they let on, but it's pretty, simple what I see in the chart there. But I mean, when you see a person working with someone, it's very different. I mean, they're not doing that standard 3 thing, they get to know that person. And so yeah, but family, that's the biggest thing, is just identifying what they have. And then as far as a huge list, maybe pass that along to the med aid or whoever it is, and hey, here's your cheat sheet. And so go from there. There's 25 of them. So yeah.
Here's a question. You have to move closer for the question. Yeah, sorry. So the question is, are SSRIs detrimental to dementia? What SSRI would you recommend for an elderly lady on Prozac for more than 7 years? 10 milligrams dose, helps keep her happy. I don't want to change it, but is there something better?
Well, so Prozac, that is an SSRI, and it's also kind of part of that Beers list that I was mentioning, where it's medications that are inappropriate for geriatrics. And so, first of all, if she's wanting to stay in that class of medication, I'd have to say, as of right now, my favorite-ish is probably sertraline or Zoloft, because it doesn't have as many side effects or drug interactions, excuse me, as the other SSRIs. If she's having, there's so many different things too, like Prozac. What made it an inappropriate thing for geriatrics for a long time was it can decrease their appetite. And so if you have a person that's struggling to have a robust appetite, you don't want to give them medication that's going to make them lose it more, right? And so, Zoloft would probably be the one I'd say, and the doctor who will want to probably taper that doesn't need to, because it's got a really long half-life, and so you can just do a swap-a-roo and no tapering.
Thank you. Other than vitamin E, what other supplements would you recommend?
They're going to hate me. So I'm not the biggest of supplement guy. I don't see enough evidence for each study that says it works. There's an equal amount that say it doesn't work. And so I stick to I showed those alternatives and whatnot that, they're saying potentially could help. But for me, I want to maintain, when it comes to supplements, I want the things that we know really do have effect, like vitamin D and calcium. I mean, we know a lot of people that are in geriatrics, they have osteoporosis, and so they're on medications that are helping with their bones. And so we know that if a person falls, they're at a higher risk for infection and then ultimately, you know, passing away. And so from where I'm at, I just want the real deal. And so I focus on, hey, let's keep those bones as strong as possible. Let's keep that vitamin D up. And I don't get caught up too much on supplements for that. So I'm probably the wrong guy when it comes to supplements. They're all hating me right now. You got rid of my multivitamin, but you know, it's kind of, yeah.
Can you address the medications that may be harmful in, for example, Lewy body dementia?
Well, the biggest one is antipsychotics. There's some studies that came out many years ago that showed people with dementia that are on an antipsychotic, they are at a higher, they have a higher risk of dying versus someone that was not on an antipsychotic. And so out of that came all these laws with CMS for the skilled facility where there needs to be gradual dose reductions. And that's the biggest drug that when it comes to dementia, and the negative would be an antipsychotic. And there's two types. There is the first generation, the typical antipsychotics, and then there's the current ones, which are the atypical antipsychotics, which you'll see the quetiapine, risperidone, and whatnot. And so those are the ones that send me to the Dalles once a month for a meeting, because we know that those medications have a really nasty side effect profile. They have their purpose. With dementia, that's, I mean, it's an area that I was initially like, get rid of them. But then when you go into a facility and you see what's going on, it has somewhat of its purpose. And from the standpoint, doctors aren't going to stop prescribing it. I mean, I every month am trying to get those reduced or removed, and they just will not stop doing it. And so that's something for the medical community that they need to, you know, they need to be hit. I don't know how they can get hit, but that's how you need to go. But yeah, that's the biggest one.
Do you recommend measuring vitamin D levels to know for sure if they're
Oh yeah, yep. So vitamin D, magnesium, those are ones that I will ask for labs. And we're in the Northwest, so people are probably walking around with vitamin D deficiencies for sure. Because looking at all y'all milk a mag, except for Mike over there, he looks like he's got a tan. But for the most part, we're we've probably got a little bit of a deficiency, and so I ask for that lab, you know, pretty often.
So is there any risk to kidney function if you're taking too much
Vitamin D?
of vitamin D?
So people always want to go high. So vitamin D is a fat soluble. So like you know, when you're like vitamin C, it's water soluble, so you can take it and just pee it out. Like all these supplement stores that you see that are making millions of dollars, half of that millions of dollars that you're spending is just going into the toilet. And so vitamin D, that can accumulate in your tissues. And so I would not have a person just start willy-nilly taking high amounts. I mean, go get a level. And if you're deficient, then they'll give you, it's a little tiny 50,000 international unit pill that you'll take once a week for like 6 weeks, and then they reevaluate it. But I would go with just a standard. Like I take 2,000 IU a day, you know, and but I just go with whatever the current standard amount is, and don't overdo anything until you get a lab on that one. Yeah.
Do you recommend potassium with vitamin D to help with the absorption?
I'm not the biggest fan of potassium being taken without your doctor prescribing it, because a lot of people are on what you call water pill, and that is furosemide or Lasix. Well, that is diuretic, and so you will you'll lose potassium. So then they give you potassium with it, and so potassium hyperkalemia is a real deal. Google it, everybody. It's a real deal, and so I would not want a person just taking potassium. Because as soon as you say, yeah, it's fine, then the person, well, he said it's fine, I'm gonna take 75 of these all at once, and then there's an issue. So yeah, I wouldn't go with that necessarily. Answer, yes, ish?
Oh, no, sorry, vitamin K2 with vitamin D, D3.
Oh, look at that. Yeah, see, this is what the supplement thing, you open up a can of worms. So vitamin K, you're talking about if a person had bruising issues, then sure, I mean, vitamin K. However, a lot of people might be on warfarin, which is the most deadliest drug we know, by the way, rat poisoning, I guess. And so you go in, you have to get your blood work. Well, vitamin K is part of blood clotting, like it's the clotting factor. And so if you start going down that route, the person will say, oh, I'm not on anything. And then you find out, oh yeah, they were on warfarin and now you're messing with some treatment. And so again, those are the vitamin K's of the world. I mean, you could probably in like a multivitamin would be fine and you'll be good. But I don't get down the individual. I mean, this is what I take. I take vitamin D and calcium. Boop. I take magnesium. The only reason why I take magnesium is I have a stomach thing. So I'm on pantoprazole or omeprazole, and that tends to get rid of your magnesium. And so I'm kind of countering it. But magnesium, vitamin D by itself. So I do a calcium with D together because you rarely can find calcium by itself. Vitamin D is like the car that drives the calcium in your bone. But I do a vitamin D by itself, which is 2000 IU at the Costco, Winco, wherever. But my calcium D, I do the Viactive, which is like a chocolate kind of thing. That's actually pretty good. A lot of people in our facilities, they get that. So if you have a hard time with the big pills, I think that's all I take. Oh, fish oil. I take fish oil. That actually will improve your triglycerides. So there you go. That's all I take. Boom. And I had a machine to test that, by the way. I was in pharmacy school and we were learning about cholesterol, and so we were covering all the different meds to take. And they said fish oil, it'll lower your triglycerides. I'm like, cool, I have a machine, I'm going to test it. So I started taking fish oil, two of those big nasty things a day, and I tested my cholesterol. And then I went back like 6 months later, and it totally lowered my triglycerides. It's just a supplement, so I was kind of trippy. Yeah,
So it's real.
it's a real deal, and that's a supplement coming from a kind of anti-supplement guy.
So one more vitamin D thing. Medicare doesn't cover to have it tested. How do you get that covered?
I have no idea. Get a
was gonna
second
say-
job. I have no idea. I mean, honestly, my insurance isn't that ideal either. So medical world, we're kind of smart. We know that if you're a human, you get sick. And so we're not going to just do like what, the Microsoft does, where they just give them everything, oh yes, have the best insurance ever. And they probably don't do that anymore because they realize you get sick. And so I don't know about the getting it paid for. Everything's like a tier system, like, oh, hey, you're not much of, you need to do this first and whatnot. But yeah, sadly, I'd probably have to pay for it if I needed a lab work.
Ask Medicare.
Yeah.
So can you address anesthesia and surgery in people with dementia, knowing that we often hear that their loved one with dementia needs to have surgery, they have anesthesia, and they're never the same.
Well, so I don't know about that never the same part of it. So one of my close friends who I play poker with and lose all the time too, he's a anesthesiologist, and they've came really far in that world. The only thing I could give advice for that is, again, when you have your person with the diseases that they have and the medications that they have, write it down, because what you're doing right here, you're like, oh yeah, got it. He's answered everything. The second you exit that door, you'll be like, crap, I wanted to ask the most important thing in the world to me and I forgot it. So have your medication list with you, have your questions with you. When you go to the doctor and you have a surgery plan, have them look at it and write it all down. I mean, you will never remember it in the doctor's office. There's that white coat thing that they talk about, the white coat syndrome and whatnot, or just, you forget. So that's the best advice I could give you, an anesthesiologist. Yeah, they've got that down to a science for the most part.
Well, that's the questions that I have from the chat, from the Q&A. Does anyone have anything else?
There were 16 there. Was that all of them?
Everything that's there is there.
Okay.
The bill is in the mail.
Hi, my mom was recently just barely diagnosed from her GP as dementia. I feel like they're kind of holding back on saying it. Her neurologist, neurologist, my stepdad's tomorrow, it's different too. Is until August. They couldn't give her for like 5 months. What should I expect once we go to the neurologist? As far as medication, maybe giving her, what
I would go, well, the biggest thing I would do is bring the medications with you, so you have that list. And again, the questions that you have at home, write those down at home. That way, when you're there, you hit them up with all the questions. When I went for my hip replacement, I freaking had all that written down and went in there and I was like, hey, we're gonna just sit here and do this checklist. Okay, yep, and because I knew I wouldn't remember it because, you're uncomfortable, they're kind of working through it. But the biggest thing for any kind of treatment is you want to have the whole history up there, like that's how I communicate with doctors. I do a background of what the person is, their chief complaint is. Then I have, these are the medication lists that they're on, the allergies, and then I present it there. And so, I mean, that is honestly, I can't tell you if that doctor is going to be a cool guy, sad guy. I mean, it's tough to say, but the main thing is having all of the medication and the history with you. That way he can look at it and then sculpt his, his what's next for you based on that. And so, I mean, as far as the dementia medications, I mean, it's pretty, once that diagnosis occurs, I mean, it's just a matter of, if you want to have that one medication added or not, but yeah.
So the expectation is that they will put her on something.
Oh,
In your opinion.
I mean, for the most part, yes. I mean, I don't have any patient that is with dementia that is not on at least Namenda or Aricept, unless they were on it for a long time and then they're maybe going to hospice, or every now and then the doctor will let's get rid of it, but for the most part, they're all on that. Yeah.
So we have a question that's not necessarily medically related, medicine related, but it's a weird question. My mom, we know she has dementia, but she's not been to a neurologist. How important is the diagnosis? She's 91.
Oh my Lord, I mean, that's everything. So, because if you ignore it, suddenly mom gets out, makes it in the news because she's, got lost. I mean, those are really important things that you need to not, if like Chifa Snow was saying, if you notice that the person's different, like this is not normal behavior, what I'm used to, then you're running the risk of putting them in danger. I mean, hiding from it won't make it better. I mean, unfortunately, I have people in my life where they just ignore stuff and all of a sudden it hits you and there's nothing, and then bad things happen. And so that, I mean, you need to immediately, get this diagnosis and there'll be a relief. I mean, honestly, I know for me, if I'm sitting there scratching my head, like, why in the heck is that person doing that? At least if I had that answered, I mean, that would be important to me. And yeah, diagnosis is very important. Can't say that enough.
You think they have to go to a neurologist to get that diagnosis?
Oh boy, I mean, that's a little out of my pay grade as far as who per se to go. I mean, it's such a whole bunch of different things that come into play. There's something wrong. Like for me, what I would recommend is, there's something wrong. You're seeing this change and you're not familiar. Go to the primary care physician. Go to your primary doctor. I mean, don't jump ahead to some specialist, because insurance probably won't pay for it. But go to your primary care doctor. If you don't have one, then find one and then start from there, because that's why they get paid the big bucks, right? I mean, they're just ones that say, hey, okay, now I believe this is that, and so let's transition them. My mother-in-law, she has COPD, and she just no all the time. Everything's fine, even though I'm hearing her puke in the background from coughing and all this stuff. So finally, I'm like, hey, Betty, can I? She's let me say this, by the way, HIPAA and all that good stuff. But I said, hey, can I write a note to the doctor, knowing that she is so stubborn that she's like the toughest lady ever. I mean, when I found out what all she had, I couldn't believe it. But I knew that if she saw it, she'd be like, no, I'm not going to do that. So she was the type of lady to go to the doctor. I'm fine. I'm good. Everything's fine. Well, I did the most doctor level nonsense that she would never in a million years be able to know what I was saying. Well, that doctor is the same doctor that I have, primary care doctor. She saw that and she goes, she's too advanced. So she sent her to a specialist. And so that's what they do. You go to your primary, they're like, oh, too advanced, or oh, this, and then they funnel you into the appropriate channel.
So is there any verification regarding light and sound therapies or music, basically vibration therapy?
Sound, music, actually, one of the pharmacists that I hired back in the day, he just retired. Dang it. He's a musician, and there's some, I mean, again, that's going to that non-drug interventions, if that person was a musician during the day or I mean, in their life, or they like music, start playing them Def Leppard. I don't care, whatever it is that makes them calm down, which Def Leppard's a good band. could skip band, but yeah, I mean, those are anything non-drug. Is anything that is not doing a drug to calm them down, like, hey, just drugs are a lazy way, in my opinion, of calming a person down, whereas, music calms me down. Yeah.
What point do they take their driver's license away? Because right now she drives every day the same route. I put a GPS on the car.
Right.
Every day the same route.
The bank.
Well, who is the like power of attorney? Like, is she like still in control of everything?
Yeah, my brother is, but I'm the secondary because he's done.
I mean, for that, I would see, that goes back to that diagnosis part. I mean, you want to get that person into the doctor right away, especially if you have those concerns. I mean, I know with your profession, I mean, that's scary to have somebody, anybody in general, but to have somebody driving that shouldn't be doing it. And so I would go to your doctor and have, and have that addressed. And I'm not sure how the power of attorney thing works, as far as, I'm sure there's a lawyer somewhere that needs to be involved, but it's important the biggest thing that I can say is be motivated and be active and get on it right away, because you don't want that.
We were flat on the tires and stuff. So she couldn't ride.
Yeah. And so, I mean, if there's some cognitive deficits going on, I mean, you want to be proactive and not, because that's just putting like a little Band-Aid on a wound, right? I mean, you really want to address that, so she doesn't get hurt.
I was a traffic engineer for most of my career, but I also taught the AARP Safe Drivers Training course for about 15 years. And it wasn't uncommon to hear about accidents, crash accidents, where people would go off the road and die, and nobody saw it, nobody knows anything about why. And a lot of that is these people who shouldn't be driving, and they're not stopped, and they end up going out and killing themselves.
They fall from trucks and all that stuff.
Or kill somebody else.
So the other thing that you can do, you can't, and I'm not exactly sure how to approach this, but you can get to the drivers, Washington State drivers, whatever it is, and advise them that this person probably should not drive. And they can refuse to give them a license if they don't pass whatever test they give it. They may just say, you've got to come down and turn your license and you can't drive it.
Or give them a test.
Try it out,
Send a letter or something.
Find out from them how you should go about that, because I know that that's a possibility.
Both of the hospitals in Vancouver have simulators that they actually can go through a simulation. And they will tell them right then and there whether they feel that they should drive or not. And again, depending on, a recommendation is that you get her to the doctor as soon as you can. And very often, if families can't get them to stop driving, the doctor can. And a physician will write that letter that you're talking about, and then the DMV sends them a letter.
That's what needs to be done then.
Yeah.
If I put a GPS on the car, I can track where she's going, and she's doing like 20 miles an hour on 40. And she's doing just like crawling along. So I mean, she's kind of a hazard out there.
I think that's the only freedom she thinks she has. You were talking about those terms you gave me, the sundown, but there was a
Right.
couple others that you had said. Mine's about how they can't remember things, so they repeat what they do remember. Yeah, I haven't written down.
But you know what, the biggest thing is, it boils down to this, that you're a family member, that you are noticing this. I mean, there are some people where they're not aware of it, and that's where those accidents that you hear about. And so honestly, now that you're aware of it, I mean, this is something that should be in a sense, a 911 emergency in your family,
Yeah.
And so now that you've identified that, I mean, if you're tracking this person, you're taking out air out of the tire, clearly this person should not be driving. I'm just going to go with that,
But you can't stop.
Yeah, well, I mean, they'll eventually the family will, I'm sure there's people here that probably have a better, this is what we did story than what, I'm thinking
Oh,
about.
we hear amazing things.
Yeah.
The battery is out of the car. Or the keys are missing. Or, all sorts of things.
The car's in the repair shop.
The car's in the repair shop.
But it never comes back.
There's another aspect of this, though, that you have to be mindful of, is that if that person is such that they have to have transportation, if they have to depend on that car for their daily life to get to the grocery store or whatever, then you're just putting them in a tighter box. So my mother, when she got to the point where she shouldn't drive, we told her that she had to quit driving. She's, okay, but keys had to be hanging on a nail right by the door, and the car was parked right out front if she ever needed it. But she had grandchildren that would come and take her wherever she wanted to go. And that worked for her. After about 4 or 5, closer to 6 years of that, she finally said, okay, I don't need the car. So you have to be mindful of that person's needs too.
Yeah.
You were asking about the power of attorney. I mentioned that we just recently had our wills redone, including my mother-in-law's, who's 96. And the lawyer told us if we ever needed to activate the power of attorney, although Diane has full power of attorney with her mother, but you need a letter from the doctor saying that that the person has dementia.
Okay.
It's all about that doctor.
Yeah.
And we actually, because you have a brand new diagnosis, we have a little booklet here from the state of Washington, the Dementia Action Collaborative, that is called the Dementia Roadmap. And it basically walks you through, okay, you've got a new diagnosis, these are the things that you need to do. And it's a 28-page booklet, skinny little thing, but boy, it's got good information in it. So we'll give
My
that to
sister
you.
and I are just like, we're back and forth, our conversations are
Yeah.
quite flippant.
Yeah.
Yeah. We just don't know, we're so out of sorts, we don't have any, you can read about it online, but until you're able to talk to somebody, and somebody else is going through it, it's pretty intense.
It's very
And
intense.
she's taking care of my stepfather who's 86, and he has Parkinson's and onset dementia, so I've got 2 of them there just feeding off each other every day. So luckily they're not far from my house. So.
Remember what Tika Snow said about the caregiver taking care of the caregiver? Remember that.
Yeah.
So, well, I think we've answered our questions, unless anyone has anything else. I do want you to know that we have some literature over there besides cookies. So there's stuff if you want to take a look at it. And the reason that we have the dog and the baby doll there is that this is a program that we have called Marianne's Babies. And when Charles was talking about non-medication interventions, and we were talking about the seagull, well, people that have pets that are no longer able to have their pets, we're often able to provide them one of these robotic animals, and there's cats and dogs. And if they are very, very fond of babies, then we can provide a baby for them. Marianne, the person that our program is named after, when we gave her a baby, she practically never put it down until the day she died. So, those are definite non-medicine interventions that are very helpful with keeping people calm. So thank you all for being here. Thank you, everybody on Zoom. And Charles was our guinea pig for our first hybrid education.
Awesome.